All right, hey there class. So I am going to try to share my screen with you. Um, and I'm gonna go over vitamin D and the war fighters. So just a reminder, I'm specifically a dietitian for the Army. And so all of my briefs and all of my research aims at soldiers. I'm gonna change this lighting here. There we go, that's better. You're welcome to use this in your discussions. You can cite the presentation, or I encourage you to go find your own research because I am not currently in a dietitian role. My briefs have not been updated in probably a year and a half. So there might be some new information out there that maybe you can teach the teacher, okay? So let's just talk about vitamin D and the warfighter because we have a lot of new information about vitamin D. So what you're gonna see in your reading is that vitamin D is a fat-soluble vitamin and it pertains primarily to your bones. Now, something I want you to know is that as you're reading about micronutrients, your vitamins and your minerals, our original understanding of micronutrients was through the lens of deficiencies, because we could observe deficiencies before we had things like microscopes and high quality blood tests and the ability to pull biopsies from bone and whatnot. Okay, so we observed first and foremost the things that happened when things didn't go well. So when things were deficient, so think scurvy. Okay, scurvy is a significant vitamin C deficiency. Okay, so it's an actual deficiency. Now, the DRIs, as we know them currently, are primarily based on those deficiency studies. So vitamin D is the same thing. That our DRI for vitamin D was based on what do we need to give people to prevent rickets, because rickets is the deficiency associated with vitamin D. Now we've had to change our thinking in recent years, okay? We've had to change our thinking because now there's something known as a marginal deficiency, meaning it's not optimal. So we don't have an overt deficiency. We're not seeing scurvy, we're not seeing rickets or beriberi, but the blood levels look fine, but the storage levels are low. So there's not something to replace it when those blood levels go low. So we may not be in deficiency range, but we're not optimal either. Okay, so that means that you're taking in some of that item, but not really enough to reach optimal health. And that's kind of where we're at with vitamin D, is we're realizing that there are receptors for vitamin D in places other than just bone. So vitamin D is used for other things in the body. Vitamin D is actually used as a hormone in the body, believe it or not. We're not going to go into that in this class because that is more of a upper level dietetics class for a 4-year study of nutrition if you're going in depth. So in this class, I'm not going to get into this, but vitamin D can act as a hormone. So it can go into the nucleus of the cell, if it's activated, by the way, and mess with your DNA. So it can it can turn on or off genes, or say, I want this gene transcribed so that now your body is utilizing whatever that gene transcribes for. Okay, and if you haven't had biology, that just means that, like let's say you have plans for something in a computer and a 3D printer, your genetics are the plans in the computer. When we transcribe something, you could think of that as like sending the information and translating that information to the printer. And then we translate it and the printer prints it so that it can now be used. Okay, so that's not a perfect metaphor, but it kind of gives you at least something to chew on, okay? So vitamin D can go in there and say, I want the plans for this. And then it goes and gets printed, okay? All right, so our objectives are to describe the traditionally known function of vitamin D, which we kind of just went over, describe the metabolic pathway of vitamin D. You don't really need to know that for this class. Explain the laboratory assessment values and considerations for interpretation. Again, you don't need to know that for this class. This was actually designed for doctors and nurses, so it's going to be way more in depth than the purposes of this class, but I thought you might find it interesting at least. And then describe the relevance of vitamin D status for the warfighter. So, a little background on this. Soldiers are at risk for vitamin D deficiency because of the nature of the uniform. We are covered wrists and all the way down, okay? So from neck to wrists, we're covered. And that makes it very hard to get vitamin D from the sun. Now, the sun can do its job when it has access to your skin, and surface area of exposure matters. It also matters what color skin you have. So the darker you are, the harder it is for your body to take that sunlight and convert the vitamin D into an active status. So it takes longer in the sun to get adequate amounts. So soldiers face various nutritional challenges in the field and in garrison. So in the field, meaning when they're like out doing stuff. Sorry guys, my dog is being weird. Come here, Rox. And in garrison, meaning on base, okay? So on base, they're primarily eating at dining facilities, or they're eating according to whatever they want, which could be fast food. And then in the field, they're really at the mercy of what we're feeding them, really. So that could be MREs, that could be food from a field kitchen, okay? And then musculoskeletal injuries are very, very common and a significant threat to readiness. And vitamin D and its relationship to bone is an obvious segue into that, okay? All right, next, you don't really need to know this. Just know that there are lots of different names for vitamin D. If you wanted to do some research, these are some things that you could look at. There is a difference between vitamin D2 and D3, and you will see that, excuse me, on the supplement market. You will see D2 and D3, and as a practitioner, as an Army dietitian, I am allowed to order labs and order supplements for people when they need them. And I had to do some, part of this is educating doctors on if they come across a soldier with a low vitamin D status, what do they order and in what amounts? And so basically I was trying to convince them to order D3 with this presentation, okay? You guys definitely don't need to know this, so we're just gonna skip that, okay? And this is just some justification for why the DRI should be changed. So what these societies are discussing is the difference between what our current lab value understandings are and then what you see at tropical or subtropical latitudes, so people who are exposed to the sun, what do their lab values of vitamin D look like? And so it gives you like this nice picture of the red would be a deficiency, and then the red on the other side would be a toxicity. So where do we see that, and where are we assessing people versus what do we see out when people are exposed to the sun quite a bit? Okay, so the argument is we could be pushing more vitamin D, that it's a fat-soluble vitamin. The fat-soluble vitamins have a higher concern for toxicity because they hang out in your fat cells and they aren't excreted in your urine. Okay, so the water-soluble vitamins, any excess you consume is just going to be excreted in your urine, so it's not really a problem. But the fat-soluble vitamins stick around. So we have concerns about that, and that's why we're cautious with vitamin D. So you can get it from sunlight, we just talked about that. So it's influenced by season, how dark your skin is, where you're at on the earth, so the latitude, with being closer to the equator, meaning you have stronger sun exposure, whether you use sunscreen or clothing, so that will block the sun's rays, and so the sun can't affect vitamin D. Amount of skin exposed, and then age. Here are your dietary sources. There are not many, okay? So that's one of the challenges. So a little personal family story. Growing up, my dad used to tell me how his mother used to give him cod liver oil back in the day, and this was when it wasn't available in pill form, so he'd take it like a spoon of cod liver oil. And me, like, thinking my dad was my hero, like I want to be just like him, I was like, well, I want to take cod liver oil. And let me tell you, it is disgusting. Like, if you could just imagine a fishy flavored or smelling oil and you're taking it off a spoon, but it has vitamin D, okay? And this, my father's from the Azores, by the way, which is like the Hawaii of Portugal. So I don't know if that's like just a Azores thing, like maybe a wives' tale or something. I don't know that's just like what they did. It's a fishing community, so maybe, I don't know. I don't know if that's something that American families did with their kids. I have no idea. And then here's the recommendations. So, sorry guys, that's my dog in the background. Come here, Rex, come on. Come on. We'll go out in a second, I promise. After we finish this, sit. Sit. Okay, you don't want to. Okay, so the Institute of Medicine currently has the recommendation set as 600 IUs per day. Same with the Endocrine Society. But for certain individuals, they may need more. So right now, the upper limit set by the Institute of Medicine is 4,000 IUs per day. But if you look on the right-hand side, the Endocrine Society says that, we might be able to go up higher. We might be too conservative about this. Okay, so that's kind of like the argument right now is, can we or can't we? So what I'm going to tell you is, unless you are a medical professional who is checking lab values for somebody, please don't go above the upper limit on a daily basis, because on the medical side, we can, and sometimes we do. I have definitely done it with patients. But again, I am checking their lab values regularly just to make sure we're not dipping into toxicity, because toxicity is serious, okay? It is very serious. So if we need to correct a deficiency, obviously we're going to do that. Please don't ever assume that you are deficient in vitamin D. Go get a lab test, because your amount that we're going to give you will depend on that lab test. Now, because vitamin D hangs out in your fat cells, your adipose tissue, it's harder for someone, the more body fat you have, it's harder for us to get your levels up. And the reason is that it goes to your fat tissues first. So we have to saturate those, and once they get what they want, then it goes to your blood. Okay, so the more body fat you have, the harder it is to become deficient. But you still want to make sure that you're keeping an eye on those blood values so that you're not going into toxicity. So that's why I say, like, you should not be taking more than the 4,000 IUs per day and should not be trying to self-medicate, okay? And then these are just some recommendations for people who are deficient based on their lab values. And then these are the populations that are at risk for deficiency or an insufficiency. Okay, it's like a marginal deficiency. So if you have problems with fat absorption in your gut, that means that you're going to have a problem getting it from your gut into your bloodstream. It may just come out in your feces, okay? If you have kidney or liver disease, these two organs are involved in the activation of this vitamin, okay? So you may get the vitamin into your body, but it may not be activated into the form that your body needs to use it appropriately. So it's just kind of hanging out. So it's there, but it's not doing anything. Okay, and we can test for the different kinds of vitamin D. So when we're looking for whether or not you have a deficiency, we're looking for a specific kind of vitamin D hanging out in your blood. And this is where untrained medical professionals may mess up, is they might be testing for the wrong form of vitamin D in your blood. Okay, so I don't think this is common, because vitamin D has been such a hot topic in recent years, but when it first became like something we were keeping an eye on, that was something that I saw, that some providers were ordering the wrong form of vitamin D from the lab. Okay, so very, very important. And then of course, soldiers and submariners are at higher risk. So here's the relevancy to warriors. We know that there is a link to physical performance. So we see relationships between muscle and bone injury, muscle weakness, neuromuscular function, so going from your brain to your muscle and all the connections in between, and then testosterone levels. So this has a significant impact on ability to build muscle and strength and even recover, okay? And then cognitive performance. So we see faster cognitive decline with individuals who do have lower vitamin D levels across their lifespan, depression, prolonged recovery from a moderate or mild TBI, and elevated inflammation in the body, and PTSD. So there are some interventions taking place with soldiers right now where I know that I've tested most everybody that came through my office to make sure, because especially if they were up for a deployment, because that risk of TBI and then PTSD, it's just increased. Some things that we're learning about PTSD is, well, with the TBI, we see, that is an obvious trauma to the brain. But what I had read some years ago, and I'm not sure if this has been disproven, I used to work on a PTSD ward before I joined the military. And at that time, the research was just starting to come out with how we think there's micro trauma to the brain with PTSD. So we keep calling it this invisible wound, or this invisible battle wound. And there were no so, quote unquote, physical ailments. They previously thought that it was solely a behavioral health or mental health problem. But at that time, and again, I haven't been working in this area, so it is worth checking out. At that time, they thought, you know what, there actually might be some micro trauma that we just couldn't see before, and now we can see it. So that's going to change treatment a little bit. So now we have something physical that we can treat instead of just therapy, right? And maybe there's different drugs. And maybe that's why the drugs that we had at that time didn't work very well. It's because they weren't targeting the real problem. We didn't know what the problem was, okay? All right, so with physical performance, bone health, of course. So we want to decrease that risk of stress fractures. I hear somebody coming down my hall, and I'm going to keep my dog entertained so she doesn't bark. Reduce muscle strength and strength injury or increased injury risk are also some problems. So there's a very interesting interplay between the NFL and the military, because those are both populations that are at high risk for TBIs. So there's often a lot of football studies that end up being pretty relevant to the military, believe it or not. So that's why I included this football study. Specifically, this is looking at injuries, so not necessarily TBIs, but some of those movements are a little similar to military movements. They might be quick, they might Okay, sorry about that. She's cute and she's not very big, but she's really loud when people knock at the door. Okay, moving on. Physical performance, so testosterone regulation. So testosterone is another hormone. A lot of these sex hormones are related to fat. So for men, especially bodybuilders, when they get their body fat really low, it starts to affect their testosterone. This is one reason they really struggle to put on more muscle when they've cut so much. Okay, so now taking vitamin D is not going to raise your testosterone beyond your natural levels. It will only, so let's say you already have good vitamin D status. Taking more is not going to give you more testosterone so that you can get huge, okay? Only if you are not in a optimal range could it possibly help you. Now, that's not to say that, let's say you're not in optimal vitamin D status and your testosterone is in a normal range. Well, maybe you'll go up a few ticks, but it's not necessarily going to put you over the normal range, theoretically. So those are some things you have to consider when you're reading medical literature is, was this study done on people with low testosterone or was it done on people with normal testosterone? Okay, and just of note, women, we have testosterone too, we just don't have as much, and this study was not done on women. So I would gather, this is not something that I've researched, but I would gather that perhaps vitamin D could have an effect on our hormones. So potentially testosterone, potentially progesterone and estrogen, okay? So that's not something I've researched, but if it has an effect on testosterone, it stands to reason that there's a potential there, okay? So now we do have a link between vitamin D deficiency and an increased risk for depression, and then we do find that it is neuroprotective in TBIs, okay? And including it after a TBI has occurred has shown some promise. So this would be like almost immediately following, or once that individual, typically a soldier, reaches a hospital for their primary care. And then PTSD, suicide, anxiety, sleep impairment, it can help in these areas. Now, how much it can help, that's the question, all right? Okay, so that is the summary. I apologize for my ill-behaved dog. Hopefully it was not too distracting. And if you have any questions, please shoot them my way. I'd be happy to answer any questions on a video. And do a little research if you need me to. You know, this class is all about you guys. I want you to make sure that you get the information that you want, but I also want to make sure that you learn how to find it yourself. Okay? All right, thanks for watching, guys.